Okay, here we are with chapter 14, psychological disorders. This is the second to last chapter in your book, the penultimate chapter. Next week, we'll talk about therapy. That will be the last chapter. And then you can finish the activity and quiz for that week, take your final, and be pretty much done with the course. How exciting is that? I think I've kind of loved this journey with you, even though half of it's been without you, sort of, because of the shutdown. But I hope that you've seen some really significant differences in your understanding of psychology from before you started the course and now. And I'm kind of excited to hear from you what those might have been. So, psychological disorders, let's first talk about some of the major issues in terms of deciding what a disorder is. And the first thing to talk about, and we'll spend a little bit of time on the future slides, I'm just going to give you an overview. First thing we'll talk about is what is abnormal? What does it even mean when we say this is abnormal behavior? I know there's a class that we call abnormal psychology. Every college pretty much has this class. They call it abnormal psychology. And basically you go through all of the categories of disorders and you cover most of them. And then there are some people, in fact, I have a former client who is starting kind of a movement about this abnormal psychology name. She doesn't like it. And she's kind of saying, let's change the name of these classes. Why do we have to call it abnormal psychology? That's part of what the question is. What is abnormal? Why do we call it abnormal? How can we discriminate between what is not healthy and what we're calling abnormal? What are all those things? And then we'll talk about what is the DSM, what is the word etiology, what is the cause of some of these, and then I'll tell you about an example. All right, so let's start with the example first. This example is about things that contribute to depression. So depression is a psychological disorder. The interesting thing about depression and some of the other disorders people use in these ways, people will say, oh, I'm so depressed about this. And they're actually not depressed. And their symptoms are not anything close to having what I would diagnose as depression. But people use it all the time. I'm so depressed. I'm really anxious. Or a lot of times people will say, I'm really OCD. He's really OCD. And they don't have OCD. And what they're describing is not OCD. But people use the term a lot. And so it's important when we talk about psychological disorders to discriminate between the kind of cultural usage of some of these terms versus what the actual clinical criteria are for having those disorders. Because the cultural usage is not how people in the clinical world understand these disorders. And so if you say you're depressed, you might just mean you're bummed out for the day, or you lost your favorite t-shirt and you're so depressed, but you're not really psychologically going to meet criteria for major depressive disorder. All right, but that said, there are some factors that contribute to depression as a psychological disorder, so that these factors contribute to being diagnosed as having a major depressive episode, perhaps. These are not all of the factors, but these are definitely things that help create that depression. Depression can happen for some reasons, for lots of reasons, but it's never as simple as the myth of I have chemical imbalance. That's not an accurate way of describing what happens. The chemical imbalance myth, when someone says, well, you just don't have the right balance of neurotransmitters in your brain, there's no data that supports this. I know we've mentioned this before, but it's important to recognize that for depression, this is not about a chemical imbalance per se in the brain. There are things that really do contribute, and we have a ton of data on what contributes to depression. Chemical imbalance really isn't it. One of the most interesting recent, say 2010 or so, explorations into the causes of some depression are this new idea that depression is an inflammatory disease. What that means is when you have a higher level of inflammation in your body, you're more vulnerable to depression, And what they've seen is that when certain patients were given medications that created inflammation, they were much more likely to be depressed. Or when they were given medication that solved inflammation, they were much more likely to have their depression go away if they were depressed. And so this kind of interesting research led people to investigate more thoroughly this idea of anti-inflammatories or inflammation and depression. So interestingly, a lot of these things that are factors that contribute to depression are things that also contribute to inflammation. So very, very interesting. And I remember when I first read this research, one of the things that, or there were actually 5 things that I had been suggesting for all my patients with depression. One of them was vitamin D, one of them was exercise, sleep, and probiotics, and I can't remember the 5th one off the top of my head right now because I didn't have it written down, but it doesn't matter. All those things are anti-inflammatory. Probiotics, anti-inflammatory. Sleep is a very powerful anti-inflammatory. So is exercise, sunlight, vitamin D. When you get stressed out, stress is pro-inflammatory. And so think about how you're thinking and your self-talk, your reactions to yourself, or if you're like being a jerk to yourself, those will create inflammation. So that body-mind connection is a real thing. I read kind of a hilarious but super, super true meme the other day that I wish everyone could really take to heart, this idea that if you've always thought that being a jerk to yourself was an effective method of self-transformation, it should have worked by now. And so and everyone, it doesn't work. That doesn't work. That's not how it happens. And when you're a jerk to yourself, what happens is you're creating a sense of threat. And so the brain responds to threat with pro-inflammatory chemicals like cortisol. So cortisol in the short term is anti-inflammatory, yes, but chronic cortisol is pro-inflammatory. Other stress hormones, that sort of thing. When your body's stressed out, that creates inflammation. So across the board, anti-inflammatory life is really what you're looking for. And a life is not the same thing as taking ibuprofen. That's actually damaging to your gut, et cetera, for long periods of time. And so here are some of the things that do contribute to depression. Sleep, lack of sleep is considered causal to depression. Now, people, especially scientists, are not excited about using that C word. We've talked about that before, I think. And this idea that lack of sleep can actually cause depression. That's been documented, shown through multiple studies that there's really something there. Mineral vitamin deficiencies, those are related to depression. Things like having low vitamin D related, sometimes low B vitamins, low magnesium. There are a number of those kinds of things that are connected to being more vulnerable or having depression. And so people can take, they can get a level of vitamin D that's back up to where they need to be, and they'll find that they're less depressed. Or they can take more omega-3 fatty acids, and that's been shown to help with depression. Low omega-3 fatty acids have been shown to leave people 7 or 11 times more likely to be depressed. Okay, lack of exercise, lack of sunlight, those are definitely involved in contributing to depression and can really help. We talked about inflammation, having dysregulated thinking. This means thinking where your thoughts are distorted. Let's say you make assumptions, you're reactive in your thinking, you do the whole, I think I'm a jerk and that will help me change thing. Or I think everyone's a jerk and that will help us all change. All of those things are distorted, dysregulated thinking. That creates problems that can lead to depression. If you're interpreting the world around you as against you all the time, that sort of perspective can contribute to depression. Dysregulated emotions also contributes to depression, which that means is you're not regulating your emotions. You're allowing yourself to kind of go off. I'm trying to think of how you say it. Off-road. I don't know what I'm saying, but I think you know what I'm saying. If your emotions are out of control, and you don't know how to manage them so that you can kind of stay pretty stable emotionally, that's going to leave you more vulnerable to depression. And then finally, family dynamics, social dynamics, things like loneliness, things like living with people who say mean things to you all the time. Uh, those can all contribute to depression. And so in this kind of a way of looking at it, what we're looking at is multiple things contributing to one problem. And I think that the best evidence is that multiple things contribute to psychological disorders. It's rare that you find one thing that makes one illness. Maybe in strep throat, you might find one pathogen that creates strep throat. But most of the time, you don't really find that. And even in the case of strep throat, which we're not going to go into, that's not as clear as people think it is. It's not just the pathogen, because there's a number of people that are walking around that have the strep pathogen and don't have strep. So there are lots of interesting things involved there. The idea being multiple things contribute to our issues. We need to be looking at multiple things to help fix them. Okay, so what is abnormal? So on your text starting on page 474, you can see how the text outlines some of the criteria that people have used to try and figure out what is normal and what is abnormal. This is kind of a common criticism of psychological disorders that, here we are calling things abnormal when maybe they're not abnormal. We have all this stigma against them maybe. I think that to some extent, we can look at those criticisms, and to some extent, we can really clearly say, nope, this is not normal. This is not a thing. At the same time, there are psychological disorders that are very connected to culture. And so that's pretty interesting when you look at how one culture will produce a particular kind of disorder and other cultures don't produce that same kind of disorder. So it makes you think that there's something going on culturally or with people's beliefs, or again, with people's thinking, societal dynamics that contributes differentially to psychological disorders in one culture versus another. One example is this disorder called Coro. Some of you may have heard of it because it's kind of a popular thing to talk about because it's like, whoa, what is that? Coro, K-O-R-O. It's a disorder in Asian cultures where the man believes that his penis is literally shrinking. Now, people in America don't get that disorder. People don't come to their doctor and they say, I think my penis is shrinking. Nobody does that in our culture, but in Asian cultures, it's common enough to be listed as a disorder for them. So interesting differences in cultures can create a different sense of what's abnormal and what would qualify as a psychological disorder. And so in the text, you see part of it's about infrequency, like we don't see that behavior happening very much. Some of it is about it's just deviating from societal norms. So society basically nopes it. It's like, no, nope, you can't do that. That's not okay. It causes personal distress. That is a part of each disorder. If you're doing a thing and it's not causing you any distress, then it's harder to say that it's a disorder. Like, let's say you have this thing about having your dishes done every single day within 1 second of having them out of your cupboard or something. I know somebody like that. I know and love somebody like that. And so you get a glass out and you walk out of the room to go to the bathroom and you come back and that glass has been washed and dried and put away already. So maybe that's your thing and it causes you zero distress. Is it a disorder? Probably not, because it's not causing you distress. It's not creating any problems really. So having that personal distress piece being part of what is abnormal, that's important to remember. And then impairment in function. Is it getting in the way of your daily functioning? Is it getting in the way of your social functioning, your work functioning, etc.? That's also part of how we decide what is abnormal. But it's still a little bit hard. There's no really clear, cut and dried criteria. Okay. One example that I came up with that is really gross, really disgusting, is a person who eats somebody else's clipped toenails. Now, that's nasty, right? And we would say, we don't see that behavior happen much in society. It's infrequent. It definitely deviates. I mean, that's a big nope. Socially, a social nope. No kidding. And it seems weird. But what if the person doesn't feel any distress about it and it doesn't interfere with their life? You and I might gag and want to go vomit when we hear about it, but does that really make it a psychological disorder? Just the fact that it's infrequent and it deviates from social norms. We could debate that. Maybe it does, maybe it doesn't. But that's part of what the issues are about, deciding what is abnormal. Where do we draw the line? How much of it is your own or your own cultural or your societal norms versus something else? What are the criteria for abnormal? Okay. Next thing to look at in terms of abnormal is this idea that abnormal exists on either a continuum or a category. So most of what we do now looks at abnormal as a continuum, but people used to think of it as a category, and some still do. Some still see abnormal versus normal as a category. Like you do this, therefore you're completely in the bucket of abnormal, or you don't do it and you're completely in the bucket of normal. And so here is one way of looking at, or rather two ways, and you see it as a continuum. There are ways in which people vary along a line between completely normal and then really severe psychologically disordered. And so particularly when you look at personality disorders, one of the things that happens when you read through these disorders in the book, it does caution you in the book, and I would also caution you that you don't start self-diagnosing everything, because it's very likely that you are just fine. And it's very likely that you don't have something as severely as somebody who actually qualifies for the disorder has it. Many times people have come into my office and they will say, well, I think I have such and such a disorder. And so then we take a look at it using the actual criteria. And many times it turns out that they don't qualify for that disorder. And so then I tell them they fail their test. They laugh at that because it's hilarious, right? You thought you had borderline personality disorder, but you don't, you fail. They're like, oh, I fail, that's bad? No, that's good, that's good, that's good. And so what they're doing is they're looking at criteria in the DSM, and they're thinking that they meet that criteria without understanding what it looks like when it looks more severe or less severe. And so if you're reading, well, I have feelings of emptiness sometimes. I think, everyone has those feelings sometimes, but chronic feelings of emptiness that are to this really severe extent, most people don't even see that, because the people who have that severe amount of that one example, chronic feelings of emptiness, it's just not very frequent. So you're looking at a small percentage of the population. It's very unlikely that you actually know somebody with so much of that sense of emptiness that they would qualify for that disorder. So one of the things to look at is this idea of that continuum. Sometimes you have normal behavior, sometimes it's like mildly dysfunctional, but it's not enough to qualify as a psychological disorder. We are all somewhere on that scale on a whole bunch of variables. And so there may be many ways in which you're normal and some ways in which you're mildly or moderately dysfunctional, but that's part of being human. And you can't do what we call over pathologize and consider that, any little symptom is some indication of a problem. So a lot of times people might get a little worried, like say you're worried about your memory. All of a sudden you start noticing all the times you don't remember something, and you start stacking it up and interpreting it as, oh my gosh, I've got some big problem, some memory disorder. There's something bad that's happening. When the fact is, if you hadn't been worried about your memory, you probably wouldn't have noticed all the little ways in which we don't remember or forget things that are completely within the normal range. So that's another concept, this idea of a normal range. Normal range is a range, it's on a continuum. And so you want to look at, are my symptoms in a normal range, or have they crossed the line into something that might qualify as a psychological disorder. And I promise you, you are not qualified to tell. You can't tell on your own. You're likely to think you have more disorders than you do. You have to leave that to the experts. It takes a lot of not just training and reading, but experience in seeing and working with, to be able to recognize what is a disorder and what is not. Okay, so we were talking about pathologizing. When you're pathologizing, a lot of times what happens is you're viewing things as if they were abnormal or wrong, when in fact they are not. You might be making up new disorders. Like, there are a lot of disorders that the media comes up with, or pop psychology comes up with. Like, now we have the video game disorder or something, or you have some sort of obsession that is not normative. Let's say this was actually a example I read in the literature. There was some guy who is a new hire at a university, and he has 7 publications. And so he's constantly checking his colleagues to see how many more publications they have. And he's constantly looking at all of the articles he's working on and trying to, just obsessed with this whole getting the research done. Well, would he have research disorder? So you have to be careful about pathologizing that behavior. Yeah, his life might be out of balance, true, but out of balance is not the same thing as a mental disorder, right? So don't apply those unrealistic standards to your behavior and think, well, if I don't meet up with this standard, that means I'm bad. So for example, next one I've listed there is, let's say I was late to work and I didn't care. So that must mean I'm a sociopath, right? Obviously, I hope it's obvious that we know that that's not what it is. Or unrealistic standards like every single person other than me prays every single day with full intent and with their whole heart and all that. That's kind of an unrealistic standard to say every single person does that every day. I'm the only one who doesn't do it every day. That's unrealistic. And so think about how much you over pathologize, probably for yourself, but maybe for other people that that you pathologize. That's something to consider. All right, now we're going to talk about etiology or cause. We talked a little bit about depression in terms of an example of looking at various causes. Overall, what we're looking at this is, again, not an exhaustive list. It's not all of the things. It's some of the things. We're looking at some vulnerability factors. So there might be some biological factors, some psychological factors, some social factors that create more of a vulnerability to you having a disorder than not. Sometimes people believe, actually, that psychological disorders are uncurable. Like, you always have it, you're just in remission, or you just suppress it for a while, or maybe, well, I'm better right now, but I might at any moment have a problem again. Or there's damage inside you, like you're a damaged person and it's irreparable. Like there's something inside your brain that just is messed up. And that is not supported by any data. It's supported by a lot of myths and a lot of popular understanding in pop psych, and certainly movies, Hollywood, drama, all that, for sure. But there's a lot of data that show that disorders are not lifelong and you're not broken inside. In fact, if you're looking just at the brain, as you know, has a tremendous amount of plasticity. Things can change. Thinking literally changes the physical structures in your brains. So believing that your disorder is forever, lifelong, you can never fix it. Usually, I can't even think of one actual instance where I believe that that's true. So disorders can be created out of society, systemic reasons, how we live, ignoring people, living in a way where you feel like you're always being on the defensive or always being in danger. That's going to create some vulnerability. Air pollution, poison like lead or mercury, or not enough boron or whatever. There are lots of ways that the body is affected by the environment. Certainly there's been a recent push in terms of looking at air pollution's effect on psychological disorders. We know air pollution creates more people with bipolar disorder than not. We know that air pollution is related to a number of different problems. So that can be a thing. Certainly your genes contribute, but not nearly to the extent that people think that your genes contribute. Your family, how you were raised, experiences you've had, etc. All of these things can contribute to your vulnerability for having a psychological disorder. It's awfully hard to say they are causal because there are so many variables involved. And because, in my personal opinion, people have different ways of handling things that are also very individual. And therefore, you can't say that you found one cause because another person may handle it differently enough that that cause doesn't happen in that person and they don't get the disorder. Okay, what is the DSM? The DSM is this manual, thick manual, that is basically the Bible for disorders. You could think of it that way, although it's way more political than the Bible is. So the current version of the Diagnostic and Statistical Manual of Mental Disorders is the DSM-5. So the DSM-5 lists the current understanding of what certain psychological disorders are and what the criteria for them are also. Now, there is also something called the ICD, the International Classification of Diseases. Insurance companies want you to use those codes and not the DSM codes. The DSM is going to give you a code for every psychological disorder, and that's what we really learn from in terms of clinicians to figure out whether or not people have a disorder. We use the DSM, but then you go over and you use the code from the ICD. Interestingly, the ICD codes don't match up perfectly with DSM codes. And so what that indicates is that there are bodies of people that disagree on whether or not something is a psychological disorder. It used to be that the DSM would just describe things and not give criteria. That was a long time ago. Now they give really pretty specific criteria so that there's a lot more reliability in diagnosis. But it's still, you can still look kind of different. Like everybody who has ADHD, a little bit different because those kinds of things manifest a little bit differently. And so the criteria try to gather together, scoop up people who are similar enough that you can, give them all that title or that label of having ADHD. But certainly there are going to be a number of differences. Here's one example of politics. I think politics in terms of constructing the DSM-5. For a long time before that construction, there was a lot of research gathered on this variant of PTSD, post-traumatic stress disorder, that was a result of long-term childhood abuse, multiple problems throughout childhood. And this research, the body of this research called this complex PTSD, sometimes childhood PTSD, but complex, and it was certainly a different animal than regular PTSD. So you have all kinds of data, all kinds of very compelling research, brought it to the table when they're constructing the DSM-5, and the DSM-5 people decided, no, we're not going to make two different disorders. We're just going to continue to lump all that together into PTSD. But as someone who treats PTSD, I can tell you that there is a huge difference in the way I treat PTSD versus the way I treat complex PTSD. And it is certainly two different kinds of things. Very different. The ICD has a code for complex PTSD, but the DSM does not. So that's one example of kind of a political decision. And so the DSM is not really a Bible in that sense. It's sort of like, these are the things that some of these top people agree on, but I would take it with a little more grain of salt. Like I would want to use constructive critical thinking when looking at those things. Yes, it represents a lot of great thinking, but also, incidentally, when I was in graduate school, one of my professors was on the panel, on the diagnostic panel for whatever you would call it, the consultation panel for constructing the DSM-4, or maybe the 4R. I don't know which one, but he was working with those people, and he came back and he told us that it was incredibly political and ridiculous, and he had no respect for, well, maybe not quite that bad, but he basically emphasized how it's not what you think. It's not all just data. There's a lot of politics involved, like many things. Okay, now your text is going to describe what each disorder is, or in categories. So you will get a sense of different categories and then some of the different disorders. But again, I want to clarify for you, diagnosing is hard. You need a lot of experience. Sometimes you have to see it to know what it is. And so, for example, when I was in graduate school, we learned that one of the signs of bipolar disorder is pressured speech. And so you're reading about it, you're trying to kind of figure out what that is. People are trying to describe it to you. You know, people who have seen it are trying to describe it to you. And then you hear it. I'm telling you, when you hear it for the first time, that is what you needed to know about what this is like. All those descriptions don't help at all. Hearing it, all of a sudden you're like, oh, that is really different from, you know, somebody who talks fast. It's a whole different, we're at a different level, man. You know, people who talk fast, people that are really like, you know, that is not the same thing as this idea of pressured speech. Once you hear it, you're like, okay, that is different. That's out there on that extreme end of the continuum. It's a different animal than just talking fast. So sometimes you need that experience. Most of the time, I think you do need that kind of experience. All right, I'm going to go through some kind of interesting research snippets here for you. These are things that you probably didn't know before today about some of these disorders, just for fun and to kind of get you into the research a little bit, because that's fun, right? For research nerds. Okay, so interesting, relevant research. Did you know the majority of sex abuse survivors have good mental health? That's got to make you feel good. You know, the majority of people who had sex abuse in their life have good mental health now. Great, great research. Helicopter parenting. I don't know how many of you have a helicopter parent who hovers around you and examines every single thing you do. But that leads to low mastery. That should say mastery. Low mastery, meaning you don't really get very competent at things, mainly because your parent does them for you. Difficulty regulating your behavior because your parent regulates your behavior for you. And a lower sense of social competence. So helicopter parenting, not useful. Social isolation, painfully relevant here in our era of the COVID. Social isolation changes your brain. So if you know somebody who chooses to be socially isolated, you might want to caution them about that choice, you know, tell them to get out a little bit, because it changes your brain and it increases aggression and it increases fear. So that's not cool. Panic attacks. Sometimes people with panic will say it just comes out of the blue. I couldn't predict it for anything. It just happens. It's completely out of my control. But what we know about the body is that that's not true. Panic attacks don't happen out of the blue. Your body does signal you, and people just don't hear the signals that a panic attack is imminent. Fidget spinners. People use fidget spinners because they think it helps you. It doesn't. Fidget spinner use actually reduces attention and reduces memory. Good to know, huh? Antibiotics. This is very painful to think about, but antibiotics affect mitochondria, and they've been shown to lead to increases in psychological disorders. Anti-inflammatory drugs, like we talked about before, can reduce depression because depression appears to be an inflammatory state. Air pollution. There's been, over the past year, a big increase, I think, in the research on air pollution. Air pollution increases disorders like bipolar disorder. It can result in changes in the corpus callosum. So if you remember from chapter 2 on the brain, the corpus callosum is that part between the two hemispheres that helps with communication between the right hemisphere and the left hemisphere. All right, so two more things. We're going to go through some questions about socioeconomic status, SES, and psychological disorders. So I'm going to show you the questions, true or false, and then show you the answers. And then we're going to look at a little quiz about stigma, okay? So just kind of think about what would your answer be in terms of looking at at these questions. So first of all, true or false? These are all true or false. People who have low income or low socioeconomic status tend to have higher rates of mental disorders. True or false? And it's true. So lots of research has found poverty is related to distress. Poverty is related to the prevalence of mental disorders. Poverty is stressful, for sure. True or false? Most minority groups tend to have higher rates of admission into state and county mental hospitals compared with European Americans. True or false? And that is also true. Now, these are old data, so I would like to know more current data because this is 1980, so that's a long time ago. But they still indicate that there's a higher rate of being admitted for, oh, this is not written correctly. Yeah, minorities are admitted at a higher rate. So European Americans admitted at 137 per 100,000, and then minorities admitted at least twice that rate. Minority groups tend to have greater access to private inpatient care. Well, that seems obvious, right? So that is surely false because SES and earnings and overall all the variables, it does seem that there is less access to quality care with minorities. Again, it would be good to see what the current numbers are to see if we've made very much progress. True or false? The average length of stay is comparable for most groups, and that is true. That is true. The average length of stay is comparable across racial and ethnic groups. True or false? Schizophrenia. Is schizophrenia diagnosed more often in African Americans? And that, again, is true. It seems to be diagnosed more frequently. True or false? Rates of mental disorders are higher for ethnic minorities. That is false. We think that rates of mental disorders are higher in ethnic minority populations due to things like racism, discrimination, poverty. But there doesn't seem to be any significant ethnic group differences in the overall rates of mental disorders. True or false? Women experience more depressive symptoms in response to economic hardship compared to men. Also kind of relevant right now because ethnic hardship or economic hardship is certainly a thing now, and it's growing. It will grow, and that's false. Men's primary role is more economic still in this culture, and they tend to respond with a little more depression. Married women are more likely to suffer from depression than single women with young children. I can't imagine anyone who would think that that was actually true. So we know if you are stressed out and you don't have a lot of support, you are more vulnerable to depression. Social programs like welfare and workfare, they intervene to help prevent problems, do a good job. True or false? False. Yes, it's so sad, right? Social programs generally don't do a very good job. We know Head Start doesn't do a really good job of helping. And so you have to question, why are we pouring so much of our resources into these programs? The intent is good. The intent is good, but the actual outcomes, not so good. And then finally, minority women suffer from eating disorders like anorexia or bulimia at higher rates than European American women, and that is false. For some reason, eating disorders and rich, developed countries seem to go together. All right, last thing. How hard is it for you to get help if you needed it? And this kind of bleeds into the next chapter on therapy, but we're going to put it in this chapter. So the questions are you personally reluctant to get help? What barriers get in the way for you for getting help? Is it cost? Is it that people will say, oh my gosh, you're seeing a therapist, that's bad? Or is it paperwork or setting up appointment, finding somebody? All those things get in the way of getting help. What I do in my own personal practice to try and help with these barriers is I offer a free 30-minute consultation. That way people can meet with me without having to have any financial obligation. And so they can tell if they think that I'm somebody they can connect with enough to want to do therapy. And then I can also not waste their time. If I'm not a good match for them and I think, gosh, you want this kind of a treatment and I don't do that kind of treatment, then we don't have to waste any more time doing it that way. And another thing I do is I tell people when they're ready to be done with therapy, they start to say, you know, I think I might only need a couple more sessions. And usually I'll I can see it coming. It's kind of cool. And I think, okay, they're getting close. They're getting close. And I will tell them, look, in the future, if something comes up, just call up, have a couple booster sessions, 1, 2, 5, whatever it is you need. You don't have to go through the whole big rigmarole of getting into me or, you know, restarting the process. And just call me up. And I call it a booster session because I think then that's less stigmatizing. And so people do this actually a fair amount. They'll call me up and they'll have been a client, you know, some time ago, and they'll say, hey, I need a couple booster sessions. And I get them right back on track. Usually it's only 1 or 2 sessions, and I'll encourage them to do this earlier rather than later. So it requires less work to get them back on track. Anyway, so I'm trying to eliminate some barriers there in my practice. That's kind of how I do it. So here's a quiz for you to see your barriers. Answer with the scale. I'm just going to go through the slides. You can pause and then write down your answer. I'm not going to read all the options to you. Okay, here's how to score. You reverse score those items, which means that the score is the opposite. So for example, if like on the last one, if you scored 3 for agree, then what you're doing is you're scoring actually a 0 for disagree. So add up those ratings. Higher scores mean you have a more positive attitude towards seeking professional help. And if we were in class, we would have done this extra fun stuff, right? All right, so to sum up, we looked at what is abnormal, what is the DSM, we looked at some cool research, looked at some barriers, looked at some SES impacts. So what you're going to do next for this week is go take the quiz on this lecture and then do the activity. The activity is where you're going to get into a particular psychological disorder that you choose, and you'll just find out a little bit more about that, and that should be fun. Okay, so do that, and then I will see you next week for our last chapter on therapy. Awesome. Thanks. Take care.